So we shall
Okay.
go on to our next case. Harshal, could
Yes,
you please?
yes, ma'am. Yes. So our second speaker is Dr. Sanjay Rasal, who is a prolific phaco-refractive surgeon who is practicing for last 2 decades and in Kolhapur. And apart from being a great surgeon, he's also a great sports enthusiast. So we welcome Dr. Sanjay Rasal. He's going to present a very challenging case of cataract with iris coloboma and the way he handles it. Dr. Sanjay.
Thank you, Harshal, for the sweet introduction. And to begin with, I would like to thank Dr. Chitra Madam and team ARC. Am I visible? My slides are visible?
Yes, please go ahead.
So today I will be sharing, as Dr. Halsur has said, cataract surgery in iris coloboma and microcornea. During workup, if you see, the case is presented like this, and we may face challenges in pre-operative period doing accurate keratometry, biometry reading, and thus the IL power calculation and even peribulbar ocular injection anesthesia will be tedious in these cases. Intraoperative challenges like eccentric non-dilating pupil and very shallow SE with the crowded anterior segment due to microcornea and bulging hypermature cataractous lens is there. So we need high quality viscoelastic iris hooks to stretch and dilate the pupil, and appropriate size CTR if at all needed intraoperatively, and 3-piece hydrophobic IOL. Now let us see how the case went. First, the side port is made, then little xylocaine is injected, the viscot is injected to deepen the anterior chamber. Second side port is made, the blunt spatula is swiped below the iris to separate posterior synechia if at all they are there, to facilitate the easy placement of the iris hooks. Total 4 iris hooks are used to stretch and dilate the pupil. The 5th one is not used because I had a sufficiently well dilated pupil to carry out the further steps here. So one can use all 5 iris hooks if at all needed. The visco is washed away. Then trypan blue is used to stain the anterior chamber. Here the remaining viscoelastic adherent to the endothelium got stained, which fortunately got cleared off with the irrigation. Again, chamber is formed with the visco and deepened to facilitate the CCC. Initial attempt to get the radial cut was failed, so I tried. Second attempt was successful. The superficial liquefied cortex and the air bubbles hampering the visibility are aspirated out. The CCC is fashioned using cystitome and microforceps alternatively from either side, because entering the anterior chamber, the iris was coming in a way, so I have to try it from the other side also. Finally, I could get 5.25 size CCC, well centered. The tunnel is created. The superficial cortex is aspirated for better visibility, estimation of the size of the nucleus and hardness of the nucleus to set optimum phaco power on the panel. The center of the nucleus is buried with the phaco tip, and the nucleus is divided into 2 pieces with the horizontal chop technique. Here I always try and sub-chop the right side of the half of the nucleus into multiple small pieces with mere single hold to save the phaco energy, and all small pieces are emulsified immediately. The forces that are acting centripetally towards the tip of the phaco tip, so no strain on the zonules. All remaining left side half of the nucleus is divided and emulsified subsequently. One part of the left half of the nucleus is kept all the way in the colobomatous area to support that area. Once phaco is completed, the loose cortex is aspirated with bimanual IA, but accidentally the CCC got torn at 5 o'clock position. Fortunately, the fibrotic element saved my day on that day, and microforceps used to remove that tag curvilinear. 3-piece hydrophobic IOL is then injected into the partially into the bag and partially into the anterior chamber. The visco below and above the IOL is removed using bimanual IA, and IOL is dialed in the bag so that the proximal haptic goes in a colobomatous area to support that area and keep it stretched. All the iris hooks are removed one by one under irrigation. Then finally, IOL is dialed and its position is confirmed. Entry chamber is formed with the air bubble. All ports are hydrated and case is finished. This is how the first day and 15th day follow. Patient is very happy with the good vision. So is the surgeon, and hope all you are happy. Thank you very much. Thank you for patient hearing.
That was a wonderful video, Dr. Sanjay. Can you stop? Yeah. Wonderful video. Lot
Thank
of take-home points there. Mr. Sunil, after this discussion, you could show put the entered a short advertisement. And I have one question to the expert panel. When would you all plan to place a CTR in a case of a coloboma? Any of you can tell me? Would you suggest your thoughts on that? Gaurav?
I need to answer.
Yeah. Ma'am, I think that's a great question. So there are a few instances where I definitely want to put it. I'll start from the last part, because when I'm putting a toric IOL, I always like to put a CTR in these coloboma eyes. Also, if I'm putting an IOL and that's getting decentered, or it's kind of rotating, I would love to put a CTR. And of course, during the surgery, at any point, if I feel that my the dehiscence is enough that it's causing the back to collapse, or if there is a problem in the surgery during the surgery at any point, where you feel that your handling is getting compromised, you may have to put in a CTR almost at any point. There it would work just like a subluxated cataract, like as soon as you need it, and as late as you can go on without putting a CTR. So these would be the principles that would probably guide me.
Dr. Sanjay, would you like to close that coloboma in all the cases, or
actually I did this. I did this case under topical anesthesia, and the duration of the surgery was almost 30 minutes. So I convinced that patient to repair that coloboma defect, if at all it is a concern, area of concern, because the patient had a choroidal coloboma with the posterior staphyla, including macula. So it hardly matters for the patient as far as vision is concerned, and also the CCC margin which was there, which will over a period of time will fibrose and will take care of that defect also.
Dr. Suresh has brought out a very valid thing. It is not just a CTR, but there may be times when you would feel more confident if even a CTS is placed in these kind of colobomas. We can never take them easy. And I have not experienced it, but anyone has noticed that, it is said that you could have a fluid misdirection in these cases.
That's what I wanted to say, Chitra.
In this case, CTR was kept ready, but as the coloboma itself is a non-progressive zonulopathy, and it was a less than 2 o'clock hours. So I thought better to support that area with the PMMA haptic of the IOL.
Actually, CTS probably doesn't have much of a role here, ma'am, because CTS is only used when you have enough phycodonesis or subluxation that you want to anchor it to the sclera. In a coloboma, that hardly ever happens, and by itself, a CTS would probably not help much. CTR is there to expand the bag properly and all. There's one thing, Dr. Sanjay Rasal, I noticed that in two places where you could have done something better. When your phacoprobe goes inside and when your injector went inside, you caught the iris both times. So, I would have done with the left hand, kept a chopper or some manipulator ready on the side port, and, pushed the iris down a little bit when entering the chamber with either the phaco handpiece or with the injector. That way your iris would not have got traumatized.
Or just put viscoat near the...
I would have used visco.
No, viscoat. Viscoat will just push the iris back and then go without irrigation.
So,
what Chitra was mentioning about the fluid misdirection in coloboma is something which... the fluid goes inside the defect, hydrates the vitreous, and you can have more shallow of the chamber as well. And whatever iris coloboma and microcornea I have seen is the cataracts are very, very hard brown black. I don't know. It's a relatively soft cataract what you have seen here, but I have seen only hard brown cataracts, black cataracts, and very difficult to do phaco for these patients as well, because the chamber is shallow, the microcornea is there, there is a zonular weakness also, there's a coloboma. Multiple factors are there, but you did it very well.
Dr. Kumar. Can you hear me? What technique would you like to use to close this coloboma?
So you can do a photopupilloplasty, but as
can you be louder, Kumar?
You can hear me?
Yes.
As rightly mentioned by Sanjay, I think that what we underestimate is the opacification of the CCC that takes over time. So if you've done in the olden days when we used to do iris coloboma, and just leave it alone, the edge of the capsular rhexis and beyond that would opacify. So it really wouldn't matter as far as the light is concerned. So would I really like to close? And you'll be surprised that some of them don't really matter because they've been used to it like that for years. They've lived like this.
Yes.
So if you need to really close this, you may not need to close this.
One more point I would like to highlight here is a workup of such a patients, because having a accurate keratometry and biometry is a key. And IOL power calculation, our literature says one should undercorrect by say 1 diopter to compensate the relative anterior ELP, because these eyes go myopic if you go with the exact power. And doing keratometry is a trick. What I say is optical biometry in such cases, they don't work. Auto K will not work. So we have to believe on the manual K. What we do is ask the patient to fix the torch light which is thrown through the eyepiece of the manual keratometer. And once the torch is removed, don't ask the patient not to move the eye. And during immersion biometry, if you tilt the probe here and there, you get erroneous results, because such eyes are often associated with the posterior staphyloma, and we get erroneous results. So one should be damn sure that you keep the Prager cell exactly in the visual axis and try to get consistent spikes on the A scan, so that we will have a fairly accurate biometry as well as keratometry for IOL power calculation.
Very important.
When IOL master 700, you can do very well. It shouldn't be a problem. And I think with immersion too, you can do well.
Madam, we have Lenstar, and Lenstar doesn't work in this case.
500 IOL master Lenstar would not work. The 700 IOL master
700 may work, yes.
because of the quality, the type of laser.
But
so
immersion has given a very good results in this case.
Immersion is very good.